Okay, I'm going to start by introducing our presenter. Dr. Albert Mensah is an internationally recognized physician specialist in metabolic treatment approaches for patients with developmental, behavioral, learning, and mental health issues. He is the president and co-founder of Mensah Medical, a biomedical outpatient clinic of physicians and nurses who encompass the best of traditional medicine and natural medicine based on biochemical evaluation, evidence-based research, and clinical experience. Dr. Mensah utilizes a non-drug nutrient approach targeted to correct biochemical imbalances that may be associated with autism, anxiety, ADHD, learning disabilities, eating disorders, bipolar, depression, mood swings, school phobias, violent or aggressive behavior, schizophrenia, Alzheimer's disease, and Parkinson's disease. Patients can be seen at our main clinic located just outside of Chicago and in select cities at our U.S. outreach clinics located near San Francisco, Los Angeles, Annapolis, Maryland, and Scottsdale, Arizona. Welcome, Dr. Mensah. Pleasure to have you.
Thank you very much, Dana, and thank you very much to the audience that's listening to this webinar and joining us tonight. First of all, I really want to thank all those parents out there who have children with autism or know someone who's on the spectrum for all the hard work they're doing in trying to evaluate, find options, and not listen to individuals who tell them there is no treatment. One of the most chilling and personally disheartening things that I've heard patients say to me was that they've been to so many different doctors and some at major institutions who simply said, your child has autism, deal with it, there's nothing that can be done, they're probably going to be in an institution. Ladies and gentlemen, these individuals are simply people who by no fault of their own are just not aware. And that's because autism is such a new phenomenon, relatively speaking, in the medical community, that most individuals, most of the science hasn't yet reached the medical schools. So they haven't been indoctrinated, they haven't been trained. It's been the pioneers in the field, the individuals who have sought the true scientific nature and research and study behind this condition, oftentimes in the alternative medicine field, but also in the orthomolecular realm. These are the individuals who are truly the pioneers, and individuals like Dr. William Walsh of the Walsh Research Institute and Dr. Carl Pfeiffer and other great researchers in the past and present are truly responsible for a lot of our current information that has led to tremendous gains in not just the treatment of this disorder, but certainly in benefiting individuals who have certain behavioral challenges as a result of this disorder or condition. My goal tonight is to really sort of present to you a core piece of presentation, because I want to try to make sure we have room for questions in greater volume. So without further ado, let's move on here. Our clinical experience goes to 10,000 ADHD and behavior individuals. There are 4,600 individuals who were classified as being in the autism spectrum disorder that are also part of our experience base. There are 3,500 schizophrenic and bipolar disorder individuals, and over 3,200 individuals we've seen with regard to depression. Let's talk briefly about the history of autism. Back in the early 1900s, autism actually referred to a range of psychological conditions, such as schizophrenia, for example. Now, in the 1940s, autism was used to describe children with emotional or social problems. At that time, Asperger's syndrome was also identified. Now, in the 1960s and the 1970s, treatment relied on pain and punishment. Electric shock therapies, for example, behavioral change techniques, and LSD. In the 1980s and the 1990s, behavioral therapy and highly controlled learning environments became primary treatments, a lot more civilized than the electric shock therapies that were back in the 60s and the 70s. Today, research and treatment focuses on genetic and environmental factors, behavioral therapies, nutrients, dietary changes, and much more. Folks, if you don't remember anything from this, I want you to remember these words. Autism is treatable, and recovery is possible. Now, I know there's some doctors out there who are paying attention to this, and some might be saying, I don't believe this. Well, to you and to any other skeptic out there, let me just tell you, I'm the biggest skeptic I've ever seen. And it's amazing that I'm still even in this, that I ever entered this field, but the fact that I'm still here because of what I've seen, not because of simply what I was told. That's why we're webinar. We've seen children who have the diagnosis who have been recovered. Let's talk about the brain, for example. The brain is actually a biochemical factory. Neurotransmitters and neurological inhibitors such as serotonin, dopamine, and GABA, that stands for gamma-aminobutyric acid, are critical to brain function. Serotonin, dopamine, and other neurotransmitters are actually made in the brain from things like vitamins and minerals and amino acids. So you don't just have them already made and present and functioning. They actually have to be put together or constructed, and then they have to be activated, and when their time is done, they have to be deactivated. A genetic or epigenetic imbalance in any nutrient can actually alter brain levels of key neurotransmitters and result in abnormal brain chemistry. Chemical imbalances in autism, advanced nutrient therapy aims to normalize a child's body-brain chemistry, reducing brain inflammation and reducing oxidative stress. Let's talk about the database with regard to autism spectrum disorders. Dr. William Walsh of the Walsh Research Institute has anywhere between 90 and 150 assays of chemical factors in blood, urine, or hair for each of 6,500 patients who are in the autism spectrum. There are more than 800,000 chemical test results. What we found, what Dr. Walsh found actually, was that autism imbalances are more severe in violent behavior and mental illness. The discovery of undermethylation in more than 95% of autism spectrum disordered patients was a very key finding that has literally changed the world in the wrong direction. This particular finding has now evolved into a plethora of tests, many of which are very poorly understood, even though the originators think they understand it quite well, such as the MTHFR testing and the 23ME testing, each of which has its own positives and its own challenges, and we'll talk a little bit more about that later. Clear evidence of oxidative stress has been apparent through these brain assays and these chemical tests, as well as challenges with regard to a protein in the brain known as metallothionein, which in the autism spectrum disorder categories tends to be very well depleted. Let's talk about some distinctive features of autism. There are 6 distinctive features in general that we want to categorize as an overall picture. Number 1, there are biochemical imbalances that are seen. And as we talked about in a previous slide, they're usually much more in terms of the damage that's caused than in typical brains where individuals tend to function somewhat normally. There's also incomplete brain development. Typically, the way the human brain forms is that nerve cells tend to grow from the bottom of the brain to the middle and from the top of the brain to the middle. It's what we call somatotopic organization. Now, in autism spectrum disorder brains, those nerves don't actually meet. And that's in part where part of the problem is coming in. There's also a strong genetic disposition, or predisposition in many cases, usually revolving around oxidative stress and methylation challenges. What we often find, especially in those individuals we call regressive autistics, is that the onset typically occurs after some type of environmental insult. Also key in this process is high oxidative stress, and we'll talk. We cannot leave the discussion about a general approach without talking about the gut and brain connection. What we've seen more commonly nowadays is that the connection between what's going on in the gut and what's going on in the brain is extremely, extremely significant. Many of our important neurotransmitters, for example, like serotonin, have a high concentration in terms of production in the gut. And if you don't have a healthy gut, you're going to have a very challenged brain. Let's talk for a minute about oxidative stress and autism. Excessive oxidative stress is evident throughout autism spectrum disorders. An oxidative stress model can actually explain most of the symptoms of autism. Most autism therapies have an antioxidant property of some type or another, and many of you out there are saying, oh yes, there's glutathione and a lot of other antioxidants, and that's been a big push over time, and there's absolute truth to that. Oxidative stress has become a leading focus of research in autism. Let's talk about some of the biochemical abnormalities that are seen in autism. One that's seen is a depressed glutathione and cysteine sort of ratio or presence in the system. We also see elevated toxic metals. We'll find quite commonly a depressed SAMe or SAMe to SAH ratio. Oftentimes we see high copper and low ceruloplasmin. We can see depleted levels of zinc and depleted levels of metallothionein. Quite often we see elevated pyrroles or pyrrole disorder. Now I know a lot of you out there have heard of pyrrole disorder, and I want to share with you, I try to emphasize as often as possible, pyrrole disorder is not an end-all condition. It is actually a physiological worsened by oxidative stress. It's actually a reflective marker of oxidative stress, and it's showing you that there's a severe stress condition placed upon an individual. That can be environmental, it can be physiological, it could be biochemical, it could be emotional. But pyrrole disorder is a clue. It is not the end-all diagnosis. We often see low vitamin B6, low vitamin C, and low selenium levels in the biochemical milieu of autism. In addition, we can see elevated urine isoprostanes, more chemicals. Each of these imbalances is associated with severe oxidative stress. Let's talk about the critical role of methylation. Excessive nutrient overloads and deficiencies can actually disrupt methylation pathways in the brain. So it's not only about whether you're born undermethylated, overmethylated, or normally methylated. There are outside influences that can actually change the process of methylation. Let's explain. The body's methyl groups act like what I call genetic keys. So they literally turn on genes or they turn off genes by affecting the interactions between DNA and the cell's protein-making machinery. Okay? Because the methylation cycle is essential for mental and physical health, basic nutrients necessary for normal functioning of this cycle are absolutely critical. Too much or too little of important methyl groups can cause a methylation imbalance. Methylation impacts every important organ function. For example, balance, blood pressure, pulse, respiratory issues, gastrointestinal issues, and urinary tract function. Overmethylation, which we come to look at through the window of low blood histamine, is associated with high anxiety, depression, underachievement, upper body pain, chemical and food sensitivities. Undermethylation, on the other hand, which we see through elevated blood histamine levels, is associated with OCD, that is obsessive compulsive disorders, oppositional defiant disorders, seasonal depression, perfectionism, and competitiveness. Now, these are not all-encompassing descriptions. They're simply windows into what each one of these methylation disorders kind of looks like. Let's talk for a minute about zinc deficiency. By this point in time, everyone has heard about zinc, or most people have anyway. Zinc is in Zicam, that element that we use to kind of prevent colds from getting any worse. Zinc is many neurotransmitters, especially GABA, that's gamma-aminobutyric acid, in the brain. GABA is that calming neurotransmitter. It combats overloads of norepinephrine and extreme norepinephrine activity. Zinc deficiency is one of the characteristics that are quite commonly seen biochemically in autism. Zinc deficiency is also associated with ADHD, irritability, anxiety, explosive temper, violent or aggressive behavior. Some things that haven't been mentioned, though, would include things like short stature or growth deficiencies or challenges. Let's talk for a minute about metal metabolism issues, or actually metal dysmetabolism. The genetic inability to control copper, zinc, manganese, and other trace metals could be referred to as metal dysmetabolism. Our system is quite originally designed correctly. When we're not able to do so, we call that metal dysmetabolism. The absence of copper and zinc homeostasis, that is, the normal regulation of copper and zinc balances, and severe zinc deficiencies are suggestive of a metallothionein disorder. Metallothionein is a protein in the brain, and it functions to include or to help neurons in their development, to detoxify heavy metals, and to work in the immune response. Many classic symptoms of autism can actually be explained by a metallothionein defect in infancy, including gastrointestinal tract problems, heightened sensitivities to toxic metals, and abnormal behaviors. Why is metallothionein so important? It's actually quite the loaded question. Metallothionein is required for the development of brain cells and synaptic connections. That is, how brain cells. Metallothionein prevents mercury and other metal toxins from passing from not only gut-blood barriers to brain and blood barriers. Metallothionein is required for that regulation of copper and zinc that we talked about a little bit earlier. Metallothionein also supports immune functioning. One of the key points that I want you to remember is that the actual functioning of this very special protein in the brain can be disabled by excessive oxidative stress. What are some of the consequences of oxidative stress? Some of these consequences actually mirror classic symptoms of autism. For example, hypersensitivity to mercury and to other toxic metals can be seen. Hypersensitivity to certain proteins, for example, casein and gluten. Poor immune function. Inflammation of the brain and the GI tract. Depletion of glutathione and metallothionein itself. Excessive amounts of unbound, or what we call free copper. All of these are consequences of oxidative stress. Oxidative stress can impair brain development. Excessive oxidative stress can deplete glutathione, impair the 1-carbon cycles, more scientific stuff, we'll talk a little bit later about that, and produce undermethylation. Undermethylation, in turn, can reduce the production of glutathione, cysteine, and metallothionein, and cause excess oxidative stress. Ample glutathione is required for the proper functioning of metallothionein. Metallothionein is a key factor in early brain development. Let's talk for a moment about the consequences of oxidative stress. Oxidative stress destroys digestive enzymes that are needed to break down casein and gluten. It can also increase Candida and yeast levels. Now, most of you out there who've got children in the spectrum have usually had your kids tested for yeast, but quite often the idea of oxidative stress is not introduced as a direct correlative or causative agent or phenomenon. Oxidative stress can also lower zinc levels in the production of stomach acid as well. Key is that oxidative stress produces inflammation. What a vicious cycle, folks. Oxidative stress produces inflammation, which increases oxidative stress, which produces more inflammation. And the sequelae go on from there. Oxidative stress also results in a leaky intestinal barrier, allowing toxins or toxics to enter the bloodstream. We call that leaky gut syndrome. Let's talk for a minute about the epigenetic theory of autism. This is the theory that was proposed by Dr. Walsh in his book, Nutrient Power. The recipe for autism involves an inborn predisposition and then an environmental insult. So it's not just that you're born that way. Something had to have happened either in utero or after birth. Environmental insults during the first month of gestation, that is literally when a woman most often doesn't even know she's pregnant, can produce abnormalities in gene expression that may persist throughout life. In other words, there's a foundation that can be set literally during the first month of pregnancy. In some cases, these abnormalities can be transferred to future generations. That's the genetic component, or the genetic part of epigenetics, which we'll talk about later. Now, this could result in a geometric increase in the number of autism-prone families. Epigenetic errors are enhanced by abnormal methylation, and nearly all autism spectrum patients are undermethylated. Let's talk about some environmental and epigenetic influences. Epigenetics, once again, involves the alteration of gene expression due to chemical factors in the womb and the influence of environmental factors throughout life. So once again, there's that combination. Firstly, the foundation that's set forth in that first month of pregnancy, and then what happens in the outside world from there on after. Every cell in our bodies has the potential for expressing any of 20,000 plus genes in our DNA. The production of gene proteins, or genetic expression, can be turned on or turned off, that is, silenced or bookmarked, if you will. These epigenetic processes are more vulnerable to environmental factors such as radiation, temperature, dietary choices, toxic metals, viruses, stressors throughout life, etc. There's so many different variables here, but here are some of the key things that most of us don't even think about. Attention has really been focused on direct insults to the child from conception to age 3. Let's talk about a strategy for enhanced cognition, speech, and socialization. First of all, most therapies will include a powerful antioxidant therapy of some type or another. Secondly, methylation protocols will be in place for those who are typically undermethylated and for those minor few who are actually overmethylated. There are biochemical therapies that are aimed at reversing epigenetic errors. Now, I know what some of you are thinking, oh, wait a minute, if this is genetic, how do you reverse that? The term is epigenetic, meaning there are changes in the bookmarks. It's like someone produces a blueprint, and then someone else reads that blueprint. Well, if somebody produces a smudge in that blueprint, the guy who's reading it, or the person who's reading it, may produce the wrong product. So this piece, removing that little smudge or putting the blueprint back in its original position, can actually be accomplished. There are behavioral therapies. After the biochemical therapies and so forth are dealt with, behavioral therapies such as ABA can truly enhance the maturation of the brain. Let's talk for a minute about Metallothionein-Promotion therapy and biochemical interventions. There are biochemical therapies and other interventions that can, either adjust gene expression, that is, shift the gene to do or to code for what it's supposed to code for, or B, overcome the effect of altered genetic expression. Okay? An epigenetic tendency for high oxidative stress can be quite effectively treated using Metallothionein-Promotion therapy. This is directly aimed at developing brain cells, helping them to mature. There's the potential for permanently correcting the intestinal and blood-brain barriers. Also, this process helps to restore key antioxidant systems. Behavioral therapies. ABA, also known as Applied Behavioral Analysis, has been tremendously helpful to so many families with children with autism. It stimulates the organization of synapses and connections between nerves in the brain and in the cortex in areas we call mini columns. These are structures of organization that involve very, very directed and very strategically placed nerves in a very particular order. Part of the difficulty in autism is that these mini columns can be disrupted, and therefore nerve cells don't grow properly towards each other. So the structure of the brain actually gets shifted oftentimes in the autism scenario. Behavioral therapies can also promote brain maturation But that can be greatly slowed down by oxidative overload or oxidative stress and inflammation. That's why what we've been talking about thus far has been so clearly focused on the idea of oxidative stress, because unless you deal with that and deal with inflammation, a lot of these behavioral therapies cannot maximize your child's potential. Behavioral therapies are especially promising when they're coupled with biochemical therapy. Let's look at the idea of comprehensive evaluation. First, you've got to look at symptoms. Was this person, this individual, born challenged, or did they regress? Is there an issue with regard to metal regulation or metal dysregulation? Were there environmental or epigenetic variables that are coming into play? What are some of the gastrointestinal issues, including food allergies, sensitivities, or malabsorption disorders that are present with this individual? What about nutrient imbalances? And what about dietary controls? Testing for methylation disorders is also very key. Pyrrole disorder, that is zinc and vitamin B6 imbalances, can also be tremendously important. Remember what we talked about earlier. Pyrrole disorder is often a reflective marker for oxidative stress. The overview of treatment. First, any good facility, any good practitioner should do a thorough physical examination. The patient history that not only goes literally back to pregnancy and through the entire course of life, but also family history. Family history can be extremely revealing with regard to tendencies involving methylation and otherwise. There's specialized laboratory testing that involves usually blood and urine. Each person receives a prescribed, individualized nutrient therapy program that usually encompasses vitamins, minerals, and amino acids. Now, this program is aimed at normalizing the body-brain chemistry. But we've got to address gastrointestinal issues, including prebiotics and probiotics, by the way. Digestive enzymes tend to be extremely useful and beneficial. Antifungal elements are often very helpful, but folks, don't go out and just take these things without being tested first. The idea is test first, find out what's going on, and then treat. And by chelation, we mean the safe removal of toxic metals is important. But folks, let me tell you, we're not talking about external chelation with many things like DMSO or deferoxamine or things like that. We actually don't agree with external chelation because it can become quite problematic. It can remove good metals as well as the bad metals. Now, your brain needs the good metals in order to actually help heal itself. We utilize a natural chelation process which helps stimulate brain proteins that are already inside the individual to do their job more effectively and to multiply those brain minerals. Multiply those brain proteins. So it's a natural form of chelation, not an external form. For many individuals, there's great balance that's produced by avoiding casein or gluten or other food allergies or sensitivities. So testing for food allergies is also an important part of the regimen. One has to determine a patient's dietary requirements based upon not just family, not just habit, not just what we've read on the internet, but also by way of methylation status.
At this time, you can go ahead and enter your questions into the question pane located just below your control panel. I'm going to pause a moment to take a look at your questions.
And ladies and gentlemen, I do have to say I think for once I've actually gone under the time that was allotted for the presentation. So I really wanted to make sure we had plenty of time for questions, so please feel free at this point.
What tests do you utilize for methylation? Urine, blood, or anything else?
Yes, actually, our tests for methylation revolve around blood histamine levels. And I just want to share with you, because this is going to become a very big issue, not just in the world of autism, but in the world of behavior, depression, anxiety, and so many other elements, especially with regard to the onset of now what's called genetic testing. And people don't quite know or understand that when we're looking at genes, it sounds very high-tech, but here's the bottom line. The question is, what are these genes doing? Many of these genetic tests are not quantitative in nature, and they're barely qualitative in nature. They give you the direction that there may be a problem with regard to a gene that codes for the expression of a protein. Enzyme, for example, the MTHFR, may be functioning improperly or may not be. But the idea here is that if you've got a SNP or two, that suggests that there's dysfunction. Folks, methylation is the cumulative process between a tug of war between several enzymes that are involved in the undermethylation aspect and several enzymes that are involved in the overmethylation process. So there are two sets of enzymes in this tug of war. Many of these genetic tests only look at one enzyme or for enzymes that quite literally are not as significant in the methylation cycle. So the real question is, what's the end result of this tug of war? There is no genetic test that tells you what the end result of that war is. However, the histamine test, which is the whole blood histamine test, is a reflective marker for methylation. And it's actually the reflective marker of the sum total of that tug of war. How much methyl there is present at the end of all this, undermethylation versus overmethylation, is actually the determinant that's reflected by high or low levels of histamine. So histamine and methyl have a very powerful relationship. The more methyl is present, the lower the histamine. So methyl actually suppresses histamine, and histamine suppresses methyl. So when we see by testing in the blood that an individual has, for example, high levels of methyl, we know they're overmethylated, and when they have low levels of histamine, we know that they're overmethylated. Forgive me, I think I misspoke. People who have high histamine have low levels of methyl, and people who have low histamine have high levels of methyl. So we actually use a blood test. After all of this genetic testing and evaluation, that's the most accurate version of testing upon which we base how it is we treat methylation disorders.
I have a child who is 15. Is that too late for testing?
No, it's never too late for testing. But somewhere around age 16, we have greater challenges in terms of reversing the actual intellectual decline that's associated with autism and some of the spectrum disorders. However, there are great gains to be made in terms of behavior. A very, very sad story that I heard about in Chicago, actually, about 4 or 5 months ago. There was a young child, a teenage individual, who was actually killed by his own mother and aunt. He was trying to help this child with regard to autism, and now this is a much bigger male who is in excess of 200 pounds, and ultimately speaking, because his behavior was so erratic, his mother and aunt fell prey to their own humanity or inhumanity and actually killed the child. Now, they're certainly serving time in jail, but it crossed my mind that if these parents had actually sought out help at the right sources and had the right resources backing them, much of this child's behavior could have been altered such that it wouldn't have been so stressful for the family. We know that one of the major challenges with regard to autism is in behavior, and it can be extremely stressful. So behavior is never an element that can't be helped when it comes to the autism spectrum disorders. But testing around age 15, 16, 17, 18 is more behavior challenges and maturation than reversing intellectual decline.
Can you further explain natural chelation?
Yes, natural chelation, when we talk about that, we're really talking about stimulating the protein metallothionein that sits in the brain. Metallothionein is kind of like the policeman of metals in the brain. its major job or major task is to make sure the right balance of metals are present. In other words, if there's too much of the bad stuff, we'll call it that, things like cadmium, things like mercury, things like arsenic, metallothionein will shift, it will grab onto those molecules and remove them from the system. So by doing so, we will get rid of the wrong metals while leaving the right metals in place. Many individuals who support the idea of exogenous tell you, well, we're going to give you this drug, which is actually a very potent antioxidant. We're going to give that drug to you, and we're going to remove the toxic metals, and then we're going to give you back the good stuff that's being removed. Well, here's the difficulty. Anyone who's actually done testing and evaluation of how long it takes to bring back into the system to normal levels the good metals like zinc and calcium knows that it can take several months for you to achieve proper balance. Now, what's happened to all the critical processes that are dependent on those metals in the meantime? They actually don't have the effectiveness that they should. The idea behind exogenous chelation is unfortunately misunderstood, because what's being done is that you're getting an extremely powerful oxidative burst. That oxidative burst exogenous inflammation, and it lowers oxidative stress temporarily. Now, people confuse this with getting rid of metals, but the effect only lasts for 2 to 3 months, and then the child's behavior goes back downward. It regresses. So you chelate again, and you get this oxidative burst. And this process, I've seen people who've done this over 30 times during the course of 1 year. It's not the removal of these metals that is producing that temporary benefit. It's the oxidative capacity of these chemicals that are being used. So outside chelation really doesn't work. What you've got to do is you've got to heal the brain. You've got to decrease the oxidative stress and inflammation in the brain. You've got to regulate those metals. That's where the internal chelation is working properly. Stimulating the brain's own defenses from a molecular is what's key here. And that's what the metallothionein therapy is about.
What are some causes of oxidative stress?
That's a loaded topic all in and of itself. Inflammation of any type is certainly a cause of oxidative stress. Metals that are present in your environment, illness, emotional illness, by the way. For example, depression, anxiety. Many cognitive disorders produce emotional challenges and emotional swings that can lead to oxidative stress and inflammation. So they're physical, emotional, biochemical, physiologic, colds, flus, viruses. All of these can produce oxidative stress in the brain. So oxidative stress, while we talk about it as one subject, it's actually the cumulative effect of many different conditions often operating simultaneously. Now, it may not be one thing that turns a child into a regressive autistic individual. It may be a number of insults that ultimately lead to that final tipping point that can cause a regressive autistic to come into play. However, the key behind oxidative stress is that it brings into play a cycle, a vicious cycle of worsening conditions that ultimately increase oxidative stress and inflammation. And that's why we have to deal with the oxidative stress tremendously, firmly, and aggressively in order to have any hope of reversing the destructive potential of autism spectrum disorders.
When it comes to biochemical and nutrient therapy, are there any adverse side effects that we need to be concerned with?
That's a good question. Generally, properly. However, any nutrient can become toxic if you're not monitoring it correctly, and that's why we use blood and urine analyses to make sure sequentially that periodically we're checking for those levels and we don't operate anywhere near toxic levels. We know what every single element we use is doing, where and when or if it can become toxic, and we protect every patient against that. So here's the point. Don't go trying this stuff at home, because I know lots of you people go out there on the internet and you're reading stuff and you're talking to your families and friends and different people and you're saying, well, I tried this and I read this. Some of what you're reading is absolutely erroneous information. And if you don't start with a proper baseline for where these nutrients are in your system, you cannot effectively monitor the progression or toxicity potentials.
You talked about brain development. How about speech development? Will the nutrient therapy help? Vitamin B12 have shown to help with that.
Absolutely. The whole vitamin B12, usually methyl B12 injections, was actually pioneered by Dr. James Newbrander, a lovely fellow. We know Jim. And he's absolutely correct in this phenomenon. Now, keep in mind, speech and language are governed by brain functioning. So what we're talking about here is approaching certain centers in the brain and helping them to mature properly and to make those connections that we talked about earlier that are disrupted by such conditions as the autism spectrum. Now, typically it's about 60 to 75% of children who try the methyl B12 injections for speech and language delay, or children who don't have speech. Usually a very significant number of these individuals do 12 injections. But once again, it's not just giving the injection. There is a methodology, there is a timing, there are concentration factors. All these variables must be properly correlated and controlled by your physician in order to achieve the proper result.
I have a 10-year-old who is nonverbal. He is doing 30 hours of ABA a week and learning a lot. We recently started the GAPS diet to help heal the gut. What would you say would be the first step or essential step to increase speech? Is 10 years old too late to see great gains in speech?
No, 10 is not too late to see gains in speech. Certainly, you're doing all the right stuff here. The GAPS diet is a good diet. I would certainly check the child's methylation status to sort of round out your dietary approach. But the other side of injections are certainly worth a trial. If you have not tried them, contact your I would actually say check with one of your orthomolecular doctors to see if they're using the methyl B12 injections, and I would try those. Those are so key, so important. And folks, listen, I don't own stock in methyl B12 injections, so I'm not deriving any personal benefit from them. What I know is, and what I've seen, is that they can do tremendous things for individuals. So don't be shy of that. Please investigate that arena.
Do you recommend a specific pre or probiotic, or does it vary with each individual?
That's a very good question. For most individuals, there are certain brands that tend to be very beneficial, and there are really a lot of good prebiotics out there. Therabiotic Complete is a very good one that's utilized by many individuals. And there's several. The key thing is that you want to make sure you've got a good number of divergent colonies, at least 5 to 7 or more different bacterial colonies need to be present in order for good gut health. And the units, of course, in terms of dosing, are very individualistic based upon the product and the individual patient. But yes, there's several really, really good ones out there, Prothera, Therabiotic Complete, just to name a few. Okay.
How do you test for growth deficiency? How do you treat that?
Well, testing for growth deficiency is not exactly something that we do. Usually it's something that's presented to us. A mother or father or family will bring in a child and say, you know, hey, I'm 5'11", my wife is, you know, and our child is at the 25th or 25th percentile in growth. And so the question becomes, is this an issue of constitutional growth delay? Is this an issue of an aberrant genetic process? Or is this an issue of a functional gut issue? In other words, a malabsorption issue? Or is this child not getting enough of certain supplementation because of things like yeast that can build up along the gut pathway and block absorption. So it's not about testing per se for the short stature phenomenon genetically. It's really about the presentation of the patient, the description by the family, and then assessing variables or factors that could cause or contribute to that situation, and then to treat each one of those variables. So, for example, say there's a zinc deficiency present. Many individual children who start a program with the correct and balanced levels of zinc, once again, determined by your practitioner, not by the internet or what you're reading in some book. Okay? The correct levels, many of these children experience growth spurts. We're not promising that for anyone, but what we're sharing with you is what we've seen empirically. Many family members will tell you, yeah, they started that certain protocol and these kids started to grow. Okay? So growth is a very complicated issue. It involves hormones, of course. It involves diet. It involves the gut health, which is why having a healthy gut is very, very important, amongst other things. And there are environmental factors such as toxins and sometimes metal poisonings that can actually inhibit growth. So a comprehensive evaluation of the growth phenomenon is important in every single patient, but usually it's the family members who are coming to us and saying, you know what, and that's usually where we begin our work.
Do you find that there are particular factors most commonly linked to sensory integration issues?
Excellent, excellent question. What we've seen is that sensory integration disorders are really in and of themselves a subspectrum in the autism spectrum world. And many of these things are more, how do we put it? They're more relevant to the areas of the brain where poor development occurred, as opposed to simply a matter of biochemical imbalances. Now, the two worlds are mixing at that point. Yes, there's bad biochemistry, there are molecular imbalances, there are genetic issues and environmental factors that come into play, but trying to isolate exactly where the dysfunction in the brain can be. Now, oftentimes what's really helpful in those cases are brain scans. Now, the brain scans will tell you where there's a dysfunction or an erratic processing. It doesn't tell you what that processing challenge is on a molecular level. So here's where the two worlds can come together, where many a brain scan, many done by the Amen Clinic or a variety of other clinics that are kind of doing these things now, can kind of tell you where the problem is, but then the biochemical evaluations, dietary challenges, looking at yeast and toxin overloads can be very key in dealing with sensory integration disorders. Now, that's part one and part two. The other side comes in the mechanical process where occupational therapy and other therapies like that and along those lines play a very important role in helping those children progress and do better. Stabilize the foundation, and then all these outside therapies can do tremendous work in helping your child progress and heal and do better.
My son has seizures, last one 3 years ago, under control with Keppra. Are there other better ways to deal with seizures?
That's a very tough issue, and above all else, as a physician, our goal is to make sure we do the best that we can to ensure that conditions like seizures are kept in as much control as possible. There are certain elements that can be helpful with regard to seizures from a natural perspective. However, right now, the best form of control that we know of still falls within the realm of the pharmaceutical industry, unfortunately. Keppra, Dilantin, a variety of other elements are truly needed. We have not advanced that far yet in terms of our nutrient capacities to overdo or to put into shadow what it is that traditional medicine is doing thus far when it comes to seizure disorders. Now, there are certain elements that can make seizures worse. So any individual who's got a seizure disorder, has a child with a seizure disorder, please be cognizant of how much manganese your child is exposed to. Now, let me be clear. I did not say magnesium. A lot of times, I'm kind of smiling here, folks, a lot of times people will say magnesium, and I say, no, it's M-A-N-G-A-N-E-S-E, manganese. Manganese can actually lower the threshold for seizures and increase seizure activity. Never heard of manganese. How important can this possibly be? Well, if you look at any multivitamin, whether it's a child multivitamin or an adult multivitamin, you can bet 90% of the time there's manganese in that multivitamin. Now, the next question may come in, well, yeah, I've seen that, but it's only like 1 or 2 milligrams. Well, folks, let me tell you, manganese is an extremely powerful element. It only takes 2 to 3 milligrams in order to cause huge detrimental effects in anyone's system who is susceptible. Okay? So individuals who got a seizure disorder, individuals who got a movement disorder, individuals with hypertension, individuals who've had a loss of consciousness secondary to head trauma, these individuals should watch exposure to manganese. Okay? So yes, indeed, there are elements like cesium that can be helpful with regard to seizure disorders, taurine in some cases, but once again, careful, and it's on an individual basis, evaluated by your doctor. These elements can be helpful, but overall the most consistent way to keep seizure disorders in check is still through the pharmaceutical line of things at this point in time.
Okay. How do you find a good biomedical doctor? What questions would you ask?
Ooh, that's a very, very good question. You can start with Mensah Medical, but there are, by the way, there are quite a few good orthomolecular physicians, especially in the pediatric community. 2 that come to mind right off the top of my head are both, interestingly enough, located in Virginia. Dr. Mary Megson, who is just an absolute dream to the world of autism treatment. She is credited with the most number of singular autism recoveries by any individual practitioner. Now, you're saying, why are you talking about this person? Well, Dr. Mensah, Mensah Medical is an organization. When we talk about solo practitioners, Dr. Mary Megson and Dr. Elizabeth Mumper, who's also in Virginia, are 2 extraordinary talents when it comes to solo practitioners who are helping to reverse autism. Now, questions you might want to ask individuals who are looking to treat your child. Number 1, how much research have you done in this arena outside of simply reading things on the internet? Number 2, how many patients have you actually treated, and what is your success rate? Okay? Any individual who has true credibility should be able to answer these for you quite willingly. The other question involves with any research institutions or organizations and things along those lines. Quite often, many people come highly recommended, but certainly there are not a whole lot in the United States and actually in the world who have the true gifts and the true capacities. It's often right now a limited number. So your search is not going to be an easy one depending on the region where you are. And don't get me wrong, I'm not saying that we're the only group out there or that we are the only ones who've had benefits. There are people, you know, from the West Coast to the East Coast. But I have to tell you, they're usually singular individuals. Don't be thrown off by going to some illustrious institution that's gigantic and hearing the words, "We can't help your child is doomed." No. The way I kind of put it is very trite, and forgive me for saying this, but to a large-scale restaurant for a particular food, and then you go to some of the smaller neighborhoods where you've got the classic menu that shows up with the best tasting food you've ever had. Sometimes it's the smaller arenas where you find the greater talent or the greater knowledge base, especially in new and developing paradigms such as this. Feel free to give us a call. We might be able to help direct you in terms of some arenas where you might move your search in search of a practitioner who can help you. Okay?
What form of chelator do you use? Is it herbal, essential oil, or other?
It's other. We don't really work with herbs and spices or roots or anything. Remember, I told you I'm a skeptic. I look at the hardcore science and the evidence there. I need to know how something is working. We actually have a construct that we put together that helps to stimulate the protein made of nutrients, vitamins, and amino acids.
How long does the testing take?
To do the testing is actually relatively quick. It's simply a matter of going to the laboratory and getting it done. The test results usually take somewhere around 2 weeks before they come back. So the sooner the child or the individual is tested, the sooner we can get to work.
And how long does it take to see improvement in speech while doing the B12 shots?
That's an excellent question. And just like the term spectrum disorder, there is spectrum improvement. We have seen individuals who literally, in a couple of weeks, have dramatically increased their capacity for speech and language. For others, it takes about 3 to 4 months. We recommend typically a good 6-month trial for the B12. And usually, if there's been no improvement in 6 months of consistent treatment, then we tend to say this person probably falls within that 30 to 40 percentile that doesn't have real benefit from the methyl B12 injections. But quite typically, within weeks to months, we see a lot of change with regard to these individuals in their language and speech progression.
You did not talk about stool tests. Are those necessary to identify yeast enzyme issues, or do you go by patient history?
That's a great question, and I want to apologize. Because of the limited nature of time, and I wanted to get to as many questions, I didn't speak about every facet involving our testing process. We do look at stool. Sometimes we look at yeast from a perspective of a urine test. There are multiple tests that are out there to determine whether or not there's yeast present and to what degree. So the important thing is that, yes, indeed, we do test for yeast prior to treatment, on average, but we're not necessarily only rooted in stool testing. Now, Dr. Liz Mumper out there in Virginia, much of her treatment is revolving around stool analysis, and she gets good results, but that's not the only thing that's done. But it can be a very significant part of the approach in the treatment of autism.
Should our children be seen by orthomolecular doctors, or is it biomedical doctor's office? Also, do you have any referrals for Canadians, specifically those in Toronto, Ontario?
When we talk about biomedical and orthomolecular, we pretty much use them synonymously. They're very, very significant overlaps and very similar approaches. And as far as I typically refer to them, the biomedical approach and the orthomolecular process are pretty much the same, okay, functionally speaking.
Have you ever seen issues with low muscle tone in undermethylation?
Absolutely. Hypotonia is not necessarily a methylation process or a demethylation process. It can be involved in it, but there can be several reasons for hypotonia or low muscle tone. And yes, indeed, that's one of the things that's very, very symptomatic in a large number of children in the spectrum, at least. And a lot of treatment therapies are around and available to help combat that. But low muscle tone is very common, and it is actually quite treatable. Many individuals can do significantly better and have done better. We've got children who are playing sports whose coordination and strength have increased over the years, and they're doing just fine.
So do you recommend biochemical therapy combined with the ABA? Any additional therapies that you recommend?
Absolutely. Speech therapy, occupational therapy, ABA, all those things are excellent. Folks, we're not saying that only doing nutrient therapy or only doing certain segments of biomedical approaches is the end-all and be-all. Absolutely not. All of these different therapies work together to maximize the capacity of any individual who's in the spectrum. What we're seeing is that, you know, if there's a fog present over the brain, it simply can't see to properly receive, process, and grow with those other therapies. So our goal is to remove the inflammation and the oxidative stress that is that fog around the brain so that it can see and receive therapies like ABA, language, speech, occupational therapy, etc. All those things come together to do wonders for the children. So it's not just nutrient therapy. I want to emphasize it's the entire milieu of therapies that are out there that are proven therapies that work in conjunction with nutrient therapy. That's the best case scenario.
What is your stance on medicinal cannabis or medical marijuana?
Oh, folks, you're asking me a very highly charged and political question. I would have to ask more specifically with regard to what utility. It's not simply that you use something and it cures everything. The real question is, of what benefit is it and to whom? In autistic children, I would say certainly not. And that's me personally and me as a physician. I do not see any utility for medical marijuana.
What are your thoughts on methyl B12 sublingual lozenges in conjunction with a tablespoon more or less based on body weight, or fish oil, or for increasing focus?
Okay, those are very different questions. If we're talking about speech and language development, the best form is going to be the methyl. If you're talking about just taking B12 or a methylated B12 to try to help with methylation disorders, there's probably a 20 to 30% utility for those forms in terms of improving methylation challenges. Now, if you're just talking about vitamin B12 in general, certainly an oral form is very, very good. A sublingual form tends to be secondary in terms of its true utility and benefit. Still an okay form to use, but on a relative scale, probably the oral is a little bit better. If you're talking about subdermal or subcutaneous injections or utilities, that would be the third line relative to creams and things along those lines. Not the subdermal injections. I'm sorry. I meant the transdermal utilities with creams and so forth.
What are your clinical outcomes for your treatment?
If you're asking what is our statistical rate, so to speak, when we're looking at the autism spectrum disorders, and that's across the spectrum involving PDD, NOS, autism itself, et cetera, we tend to do very, very well. Our improvements are seen around 75 to 85%. When I say improvements, I mean far above and beyond where this individual came in at the very beginning. When we're talking about reversals, that's become very difficult now with individuals who have been put on medications like Risperdal, okay, or Seroquel or Geodon. What we're seeing is that over the long term, these particular medications or drugs actually reduce the capacity of the brain to actually heal itself over time. So that's been a bit of a challenge for us. But overall, we would say that our capacities for absolute improvement is in the 75% to 80% range. Compliance is going to be key, though, and certainly looking at the nutrients and certainly looking at bowel dysfunction and certainly looking at all these other issues, including inflammation, et cetera, is part of the process. The comprehensive patient evaluation and approach is what it is that will lead to improvement and even reversal in individuals with autism. It is not looking for one solitary gene. That is the mistake that's being made out there in traditional medicine. let me tell you folks, part of the difficulty is that we're looking in one place when the answer lies somewhere else in traditional medicine. Many genes are involved in the dysfunction and the dysregulation that leads to autism. And there are these genes on a chromosome that are typically affected, and that's why we see the same general patterns with individuals with autism. Gut issues, brain development issues, sensitivities to metals, etc., etc., etc. These are some of the most consistent things that we see in children with the spectrum disorders. And so it's about which genes are involved, but combating those processes. So it's a global approach, which is what I'm trying to say. Not looking at one gene, not looking at one simple modality. It's an entire process. But overall, we have very, very good success rates. We're certainly in the 75th percentile range in terms of improvement, and reversals are doing extremely well as well.
Excellent. You mentioned hormones. Do hormones affect the biochemical issues, or do the biochemical issues affect the hormones? And then following this question, versus female matter in the treatment? And then is there a difference? We can then later on we can address the difference between treating a child, teenager, or young adult.
Wow, now that's a mouthful. So actually, I'm going to ask Dana to give me that question in pieces. We'll address each piece of that question.
Absolutely.
The first one was what again? I'm sorry.
Hormones. Do hormones affect biochemical issues?
The answer is yes, and the reverse is true as well. Biochemical issues affect hormones, hormones affect biochemical issues. There's an interplay, but these are separate systems. But each one of these systems can have overlay with regard to methylation disorders, where the activity of enzymes and hormones can become compromised. Okay? So they can be very, very different, and each treatment modality is based upon the specific hormone and how it relates to the person versus the chemical imbalances. Okay? Part 2.
Part 2 is, does male versus female matter in the treatment?
That's a very interesting question, and here's where I must humble myself once again and say that, okay, ladies, girls are just stronger than boys are, okay, to begin with. The female embryo, fetus, and then infant simply has a stronger relative constitution than the male does, and we've known this for a while. The imbalances that are present, males tend to be more susceptible to iron imbalances in early development, and females certainly, I mean, both are susceptible to calcium dysregulation, but with females there can also be copper issues involved. In many cases, the overall approach is going to be the same, but the very specific elements must be treated and targeted differently because of the nature of the sex of the patient. So there can be differences, yes, in the approach, but that's really more case by case, and gender falls really into probably a 10 to 15% differential in terms of how you're going to treat the patient. Okay? I think there's a part 3.
Yeah, part 3 was, what about age? Child, teen, or young adult? For treatment.
Folks, by original training, I'm a family practice physician, and we find that to be highly advantageous because we treat patients from the womb to the tomb, as they say, from childhood, from infancy, from birth, all the way to the geriatric stages in life. So where an infant is now, we know where they're going to be 5 years from now, 10 years from now, 15 years from now, 20, and so forth and so forth. So part of what it is we do is that we build into our treatment protocols things that are taking into account growth and development, hormone changes, chemistry, and physiology, all of those things as they relate to both sex and age. We know and we can tell parents statistically that your child is going to be entering a growth phase at this point, this point, this point. There'll be hormonal issues kicking in at this age and this age, and so treatment protocol is going to have to be adjusted at those particular points in time. So especially with children that are started off very early, that's oftentimes the best prognostic indicator. you're still going to have to make very specific adjustments based upon both age and sex relative to how the child progresses, especially when puberty hits. Folks, think about what happens with children who are hits, and now add that, superimpose that upon a child on the spectrum. All those variables have to be taken into account. So each developmental stage is indeed assessed a little bit differently than the others are.
What causes sleep problems in autism, and is melatonin safe to use indefinitely?
I'm going to start with the second question first because that's an easier one. The answer is yes, melatonin is safe to use on an ongoing basis. We've not seen any data yet to indicate that it is not. Sleep is an issue that not only plagues the autism community, but it plagues everyone, everywhere, without prejudice. Not that all people have trouble sleeping, but certainly there is no barrier between autism, between anxiety disorders, depression, schizophrenia, bipolar disorder, Alzheimer's disease, youth or old age. So this can cause an autistic child to have sleep troubles. I'm going to target this with regard to the gut, for example. Oftentimes, children who cannot sleep may be yeasty, they may be dysbiotic, or they may have bowel disorders. What type of bowel disorders? There could be encopresis. There can be a buildup or a poor motility of the gut that causes discomfort, and so that child is not going to be restful. They're going to be restless and have sleeping challenges. Now, these are some of the most unique things relative to the autism spectrum kids and sleep challenges, as opposed to many of the other categories that I've mentioned before. But folks, still, the plethora of possibilities exists, and that's where a good individualized history comes in to determine what in this particular child may be the cause of the sleep issues. It could be anything from high copper and metal dysregulation to inappropriate dietary capacities, to food and allergy sensitivities, to even, I'm not going to say any specific disorders, but certain biochemical imbalances can also contribute to this. There's a tremendous list that can occur, and it's simply a matter of detective work. You're going to have to piece out section by section, system by system, what may be at root here. It's not an impossible task. It just requires someone being very meticulous and careful and patient to move through that process.
Okay. How strong of a voice would it take to be heard by the conventional American pediatrics to recognize your efforts? If the statistics of success are higher than conventional medicine, then why not?
Well, what I'm going to say is going to sound not too terribly pleasant for my colleagues out there who might be listening. We tend to be a very arrogant group of people in medicine. Many of us don't listen. Many of us know what we know, and just like I sit here and can tell you what it is we've seen with our evidence, many other individuals will deny that evidence. They'll say it's not yet in the appropriate journals, even though it very well may be. Some people just aren't keeping up. But predominantly, it hasn't yet filtered in through the medical schools, and it hasn't yet filtered in through the major medical societies. Now, if it hasn't reached certain societies, which I will not name, they're not going to pay attention to it, and the people who are functioning through those societies will not pay attention. So many practitioners of medicine, and I want to share with you folks, there are scientists, there are practitioners, and there are practitioners who are scientists in the realm of medicine, and they all wear the label DO. Now, the difference is who simply practices medicine, who evaluates concepts, and who just implements them without challenge. Oftentimes, folks, in all fairness, we're really, really busy, and we've, unfortunately, by certain guidelines and certain organizations, we're relegated to seeing patients in 15 minutes. Now, that's not like for specialty organizations like our own at Mensah Medical, where we're an independent facility. But when we are under the auspices of large organizations, we have to follow the guidelines that they provide. So until we're able And we are doing our best right now to get this into mainstream medicine. But until we're able to get there, it's hard for any individual who hasn't heard the blessings from any given institution that they recognized for them to follow suit. So to try to get this into mainstream medicine, we've got research, we've got a variety of the key elements, but they have to have an open eye, an open ear, and an open heart. There are many practitioners in medicine who do have just that, so I give a lot of my colleagues a lot of credit. But there are those who are just very busy people, and bless their hearts, they're just waiting to hear from the appropriate American whatever society of whomever to say, yes, go ahead and do this. And then the training and the development begins. So there's a spectrum of folks out there who are doing their best, and we're trying our best to get this information out there. And by we, I don't just mean Mensah Medical, I mean all the practitioners who are working in these fields, often biomedical and orthomolecular.
Mm-hmm. What are the different enzymes that you test for?
Very interesting question, and that depends on what the challenge is with regard to the very specific child. Enzyme testing is not part of our first-line testing. We do things in layers. First, we want to evaluate some of the key biochemical imbalances and gut issues, but that's usually from a motility and from a yeast perspective. After that, there may be some discussion about whether or not a child may be deficient or doesn't have a functioning peptidase system or tryptase system or a variety of the digestive enzymes that are present in the stomach itself, or even sometimes acid pH, which most children have actually been tested for by the time they come to us. But that is indeed part of the evaluation process, but it's not first line. It's usually second to third line, but it typically gets done.
What is the best way to increase glutathione in a 3-year-old?
I love these specific questions. It's not a simple matter of age. It's about who is this 3-year-old and what is going on with this child's system. For the parent who asked that question, that child really does have to be evaluated first. There are transdermal glutathione situations. There are oral glutathione situations. There's a combination of the two, and it really depends upon what that child's system, especially the methylation process, might be doing relative to glutathione. Many people have checked levels and so forth, but treatment is based upon the full picture of that child. What's good for one child may not be good for another child, even though they may look alike. They may be epigenetically very, very different. And so using exogenous elements to support or increase glutathione may be beneficial for some people versus using internal systems to increase levels may be the key in other individuals. And yet the third category would be where both internal and external elements are necessary together to increase glutathione levels. So once again, the key is evaluating that individual child, evaluating methylation status, putting together all the pieces that are seen, and then determining how best to approach that one individual child. Okay? It's not autism, folks, is not a one-size-fits-all paradigm. Okay? So be highly skeptical of people who say, well, listen, take this formulation and it cures autism. Doesn't work that way. Every child is individualistic. Every child is different. When you've seen one autistic child as a practitioner, you've seen one autistic child. Okay? They're all different.
Why do you think there's such an increase or prevalence of autism? Better diagnostics?
That's a great question, and I'm glad someone brought this up. It's not simply a matter of diagnostics. We've seen over the past 10 years an increase that is almost exponential in autism. First, it was a frequency of 1 in 5,000. A few years later, it became 1 in 1,000. A few years later, it became 1 in 500. Then it was 1 in 110. Then it was 1 in 88. Now we're 1 in the 55 range. This is not about better diagnosis. These children are trying to tell us something. And what they're trying to tell us is that we are likely the culprits causing autism? Now, that's a loaded statement for me to make, and a lot of people are going to be highly critical of that, but here's the deal. This kind of shifting, you can ask any geneticist, any scientist will tell you, mutations occur 1 in a million generations or so. They do not occur with this kind of frequency. And as you recall earlier in my commentary, there's a cluster of genes that tend to get affected in producing autism, a group of genes, not just one. So what are the odds then that you've got genetic mutations happening in 4 genes simultaneously this rapidly? It doesn't happen. As a result of that, we must conclude that there is something exogenous that is going on, something outside of the natural realm, mixing with the natural realm, that is producing this increased rate in autism. Now, we're here in the United States, but folks, I can tell you that the rates of autism are increasing the same all over the world. In Ghana, West Africa, the same as in Ireland, the same as in Scandinavia, the same as in Japan, the same as in India. They're simply about injections or vaccinations. It's not simply about metals. We are doing things on a molecular level that we're not aware of. Now, many people who've heard me have heard me say things revolving around our use of folic acid, and this is a very difficult issue for folks, but you know, some things we're doing, like adding certain nutrients to all of our foods, we're enriching our foods, we're providing countless exposures to certain supplements in utero, after the pregnancy is over, and during breastfeeding, and then moving on out and forward. And I'm referring at this point to folic acid. Okay? I know some of you are thinking, but wait a minute. All these protocols involving methylation say we need to use methylated folic acid, and that's supposed to be good for you. Well, folks, that's not the case, because unfortunately what many individuals do not realize is that folic acid is not a methylating agent. The key here involves where it's acting within the cell. The area where the DNA is located, folic acid will act differently there than in what we call the cytoplasm, or the area outside where DNA is located. Outside where DNA is located, yes, in that cytoplasm area of the cell, folic acid is a good methylating agent, without question. But inside the nucleus of the cell, where your DNA lies, it actually strips the cell of methyl. Now that affects the bookmarks that we talk about with regard to the blueprint that is the human being and how things are supposed to work. Once you have those bookmarks shifted, you get wrong proteins made, you get wrong shifting and development and construction of the human entity. And one of the challenges we believe that's responsible for autism may lie in this realm. Certainly we know DNA aberrations can occur secondary to temperature, secondary to methyl, acetyl, folate, and other biochemical ratios in the womb. But there are a plethora of issues, all involving or revolving around oxidative stress. Our environment has become toxic, whether it's with, and some folks laugh at this one, but when we talk about even just electromagnetic field radiation, let's look at what's increasing all over the world. One of those things is technology. And you folks aren't going to like this, especially our teenagers who've got 16 computers and laptops and all sorts of wonderful things all over the place and devices. But how much electromagnetic radiation sits in the average household now as compared to when people of my generation were growing up? We barely had TVs way back when. Folks, I'm not that old. I'm not pretending to be, but I did happen to see an era where we went from television to computers where computers didn't exist. And we have tons of technology. We have terrible pollution. We have horrible diets, and people have heard about diets and processed foods and so forth, but I can tell you these processed foods have wreaked havoc on our children and on our systems. And it's not simply an issue of one particular thing going wrong or that's being done. Folks, it's the entire societal construct. Everything we're doing together is producing tremendous oxidative stress. And I think that's what our children who are in the spectrum are trying to teach us. They're saying, hey, put a brake on for a minute and evaluate what you're doing. Move away from the conveniences of life and ask yourself the question, can this really be harmful? One very, very interesting population I've got to tell you about, folks, one that defies the statistical odds. The Amish community. Bless their heart. We may see folks who are depressed there, who are anxious there like anywhere else, but they have less than 1% of autism in those communities. That is almost statistically impossible. It's less than 1%. There are almost no autistic children born in Amish communities. So now, let's just call that a coincidence, if you will. However, that's a pretty amazing coincidence, if you ask, for the Amish living. Now, I'm not saying throw away your TVs and your iPads and your cell phones, but technology is not real big in those communities. Processed foods are not real big in those communities, and a variety of chemical toxic elements and agents, pollution and so forth, not real prevalent in those communities. I cannot tell you with 100% certainty what is causing autism. I can tell you with 1,000,000% certainty that we are doing something that's affecting our children, and we have to stop, reevaluate, and change. Until then, my fear and my true concern is that these rates are going to increase. And they're going to increase until there really is a more unified global attempt to deal with this issue and to reevaluate all those potentials that are out there that are creating this problem. I think I might have gone overboard on answering that one question.
Well, you've got a couple of follow-up questions on that subject.
Okay.
For example, Somali community of Minneapolis, 1 in 30 kids. Is it mere coincidence? Another person is saying the Amish. Are there other groups that shy away from technology? Are there lower numbers of autism there?
I'll start with the second one first. The Amish community is certainly the one that we recognize best here in the United States, because that's the one that we are truly astonished by in large numbers. There are probably other communities around the world that also have similarly low rates. I as yet do not have facility to identify them for you, but I'm pretty certain they exist. What I do know is that in the so-called civilized world, the rates of autism are much higher than they should be statistically by simple genetic mutation alone. Now, the Somali communities in Minnesota, it's probably not coincidence. Once again, we're talking about epigenetics. We're talking about environment based upon and interacting with genetic potential. If we look at any particular group, they're usually spending a great deal of time and numbers, so to speak, intermarrying within that group. So genetic potentials can actually be passed on. Those things can be either protective or they can be inhibited or problematic. So within that community, there probably is a genetic or epigenetic predisposition that's being, shall we say, joined by environmental factors that are leading to that higher incidence of autism there.
With your treatment protocol, issues of tantrums and rage, not just the autism?
That's a great question. And in those cases, actually, there's a great deal of overlap in those behaviors with children who actually aren't in the spectrum with regard to certain treatment protocols. One of the things that we'll evaluate is the presence of yeast. Believe it or not, yeast in young children produce toxins as well as mechanical barriers to the gut, which can lead to a lack of absorption of the appropriate nutrients that lead to neurotransmitter development and production. Therefore, behavior can become quite erratic. Now, let's talk about the rage and the anger and those sorts of things. Children who are yeasty and who are toxic will certainly get signals sent to the brain and chemicals sent to the brain that can affect brain perception and therefore behavior. Gut issues, mechanical barriers, fecal impaction, stool in other words, all through the bowel, can also do the same. There's a discomfort that's produced there. Children typically do not have the capacity to, or excuse me, the psychological maturity to behave properly over and above any disturbance that's internal, such as how we as adults function. We know that if we don't feel good in our stomachs, we can put a smile on our face and we can kind of wait until we can get out of the door and go deal with whatever we need to deal with. Children can't do that. So when there's a behavioral challenge, aside from the biochemical side, we have to evaluate gut issues. Whether it's an issue involving yeast or mechanical blockage, both of those things can be very, very problematic in terms of behavior. So that would probably be one of the first and second things we'd want to assess. Certainly during that course of time, we will look at biochemical toxicities such as high copper levels, for example, or metal dysregulation. But the big ones are oftentimes yeast issues and bowel blockages and dysmotility, a gut that simply doesn't function properly. How often is your child stooling? What does the stool look like? Is it loose? Is it watery? Is it solid? How often are we seeing these things? Is it always liquidy? Is your child straining? Is your child pressing their abdomen against chairs? Are they squatting? Are they stooping? These are all indicators that there's something that's not right in the GI system. Even parasites become an issue as well, especially in children. To put it bluntly, are they scratching their derrieres in the evening time? Pinworms are very commonly associated with that particular phenomenon. Quite technically termed Enterobius vermicularis, very easily treated. Unfortunately, it's typically treated by typical medications, but that's a necessary point to eradicate oneself from these particular elements or entities. So when it comes to behavior and the non-biochemical side of things, we look at the gut and we look at the various elements that can affect motility, frequency of stooling, dysbiosis, and parasites.
Okay, we're going to be wrapping up our questions here soon, but what do elevated pyrroles and pyrrole disorder have to do with autism?
That's a great question, and it's a very simple answer. A lot. Pyrrole disorder, I want you folks out there to remember this. Pyrrole disorder is a disorder of stress intolerance, of oxidative stress, and any set of stressors in the system, whether they be emotional, physiologic, physical, or environmental, can increase the number of these pyrrole molecules that are involved in pyrrole disorder. Now, what have we been talking about all evening? A condition like autism is exactly that. It is an oxidative stress nightmare. It is a metal dysregulation nightmare. It is a stress by way of physical challenges, gut issues, growth challenges, environmental stressors, mechanical barriers. All of these elements, including growth itself, normal human growth, is a stressor on the system. So pyrrole molecules are actually telling you there's tremendous system. That stress is also going to lead to a deficiency of zinc and vitamin B6, which is now going to turn into a challenge in making your neurotransmitters, serotonin, dopamine, norepinephrine, and GABA, in any balanced fashion. As a result of that, behavior is going to change, mood swings, sensitivities to sound, light, odor, texture, rage issues, anxiety, depression, rapidly cycling mood swings or mood states. I call it the Incredible Hulk and Bruce Banner syndrome in honor of the Avengers movie. I love the Avengers. But it's that going from calm to rage in an instant makes you want to question if pyrrole disorder is present. Remember, pyrrole disorder is not an end-all diagnosis. Pyrrole disorder can be seen in autism, it can be seen in Asperger's syndromes, it can be seen in cancer, individuals who've got the flu or pneumonia. It can be seen in anxiety, depression, in copper-toxic women, women with endometriosis and fibromyalgia. There's an entire spectrum of disorders where pyrrole disorder can be present as part of the issue, not the cause and not the end result, but part of the process. So certainly where there's stress, there's pyroluria that can be possible. And autism is a huge stress disorder.
Thank you for that great explanation. How often do you see Lyme disease in autism?
Very interesting question. We're seeing a lot of kids now with Lyme's disease and pandas, and a lot of this has to do with regional situations, especially in the East Coast. Individuals are coming to us who have Lyme disease. It's more coincidental to autism. They share sometimes very similar features, but Lyme disease is not causing the autism, if that's what you're asking out there. Okay. These are issues that also have to be treated. The Lyme's has to be treated, but part of the difficulty is that when you're treating Lyme's, you're typically using antibiotics, or there's a doctor you've been working with who's using antibiotics to deal with the Lyme's for over long periods of time. Now, those same antibiotics can destroy the balance that's present in the gut, and then the domino effect occurs from there. So while you start out treating Lyme's, you now start to affect the autism treatment therapies and the protocols because you're messing, so to speak, with the gut. And the gut has to gain or regain its balance of good flora as well as the bad ones to keep the balance present so that we now maintain our capacities for appropriate growth and development on both the physical and level. So there's overlap. Sometimes there's interference because of the treatment protocols, but certainly we've seen a lot of it, and that does seem to be more increasing. Now, that I tend to actually relate to doctors being more aware to test for Lyme's in certain regions. And now we're seeing that, okay, many kids, many individuals have had exposures to, and they're getting treatment for it. But certainly we have seen quite a few kids who've come in with a coincident Lyme diagnosis as well as autism spectrum. But what we're saying at this point in time is that the Lyme is not causing autism. It may have some overlapping similarities and features.
Can you talk about gene mutations and the genetic testing out there and the relationship that it has to over and under methylation?
Wow, that's a seminar all on its own. Genetic mutation, from a prototypical medical perspective, usually takes generations to occur. Okay? Spontaneous mutations that we're referring to. Now, when we start polluting our environment, and I don't mean air pollution, I mean contamination by exogenous variables, be it excessive nutrients, whatever have you, we affect genetic expression, and that's what I'm going to refer to as mutation at this point, the effect of genetic expression. We are really still learning about this concept. The testing that we're coming up with are really sort of our new attempts at a genetic level to find out what is going on, and we're hopeful that these things are providing us Now, tests like the 23andMe and the MTHFR are, once again, not quite quantitative analyses. They're not telling us how much. They're not even telling us if these enzymes are truly working or not working. What we're saying with these tests is that there may be some type of disruption of the process that these enzymes are supposed to be working with, okay, when we're looking strictly at those genetic tests. But they're not quite so well understood because the treatment protocols that are given tend not to be very effective. So there's an issue there that we're highly suspect of, which is, one, are the tests really telling you what you want to know? And by the way, that's one of the cardinal features, one of the cardinal pieces to the puzzle of testing by the American group of physicians, if you will, by medicine in America. The test that you give is supposed to tell you what you want to know. Unfortunately, these genetic tests do not tell us what we want to know. What we want to know is there truly a methylation disorder, and is it undermethylation or overmethylation? What many practitioners are looking at with regard to these tests is undermethylation. And the people who design these tests are telling us, hey, these tests are going to give us insight into undermethylation, and here's how you treat it. Well, the problem is they're not aware that the treatments that they're offering work differently in different parts of the cell. So when we're talking about undermethylation, which occurs in one part of the cell, you can't provide that same treatment therapy in that region or that location. So while the idea is interesting, there are a lot of difficulties and points of true questions that the designers of these tests don't yet understand or fully appreciate. One example, the MTHFR enzyme. This is a molecule that is tremendously large. It has 77,000 base pairs. My analogy is saying, well, if you've got a giant semi-truck that is 3 blocks long and has 80 tires, if you have a snip, or let's say 1 blowout in 1 tire, or you're homozygous and have 2 blowouts in 2 tires, is it going to stop that truck from moving? The answer is no, folks. It is not. The MTHFR enzyme is a tremendously large molecule, 77,000 base pairs. The likelihood that 2 SNPs in 77,000, that means 76,998 normal base pairs are working for this, highly unlikely that it's going to affect the functioning of the MTHFR enzyme. So when we're talking about genetic tests and mutations, we're not as smart as we think we are. Our tests are not truly telling us what we want to know because our treatment protocols are not working when we're looking at these particular tests. Now, we're trying, folks. I know I can sound somewhat negative about some of these genetic tests, but the reason is because we have to be clear. These tests are not telling us what we really want to know. These tests are also not discussing overmethylation. If you remember what we talked about earlier, there's a tug of war between enzymes and chemistries involved in undermethylation and overmethylation, and it's the sum total that tell us what the quantitative assessment of methylation is doing in the body. The best way that we have for that right now, that determination of quantitative analysis, that's actually a blood test, not a genetic test. Those genetic tests are not quantitative, and they cannot tell us what's going on with regard to the true activity in the entire methylation cycle. When I say methylation cycle, folks, let me tell you, there are 3 cycles involved in methylation, not just one. And it's not just one enzyme. Also, each enzyme involved in many of these tests, like the COMT enzyme, for example, not all enzymes are equal. The true utility or functionality of COMT, for example, in methylation is only about 30%. There are minor enzymes and there are major enzymes at work in any process. The key is to deal with the major enzymes. I have Walsh and the Walsh Research Institute sought to investigate the availability of genetic testing for some of the other key enzymes present in the system, and they are not out there yet. So I don't want you folks to be misled, or at least I'd like you to have a better understanding about genetic testing right now. We're trying, but these tests are not truly reflective of what's going on in the entire methylation cycle. They're giving you one possible point to one possible arena out of several arenas involved in this process. Okay? Genetic mutations are there, they happen, but not with this frequency that we're seeing that's allowed autism to escalate from, by the time I entered this scene in this world of treating autism, from 1 in 5,000, and in certain communities, as someone else pointed out, 1 in 30. Okay? Quite literally, we can do an entire seminar on methylation alone, so I'm going to restrain myself because, boy, it just sizzles my biscuits when we get all these challenging tests and people get confused, and even doctors who are trying to use these tests get confused because the protocols are so wacky, so to speak, and they're not getting results. It doesn't matter who you talk to. If you're not getting results from the work that you're doing, you cannot say this is a valid test. You cannot say it's valid. That, by the way, is the standard medical statement about testing. Your test has got to do what it says it's doing. You've got to be able to treat based upon that, and you must get results. By that definition that comes from the American Medical Society, in other words, tests are not valid tests.
And might I add to that is some of these genetic testings cost thousands of dollars, and when really you can get the same results or the more effective findings and results utilized by the Walsh Research Institute trained doctors with just a whole blood histamine test, and it's only $300 to $500 for all the testing we do.
And folks, I want to just comment on the blood histamine test that Dana brought up just here. You know, we've been working with methylation as a group for 40 to 50 years. We have the unfair advantage of over 40,000 patients and their results before the rest of the world started hearing about methylation. In fact, it was actually Dr. Walsh, who I call the father of methylation, who brought methylation to the autism community specifically. Now, we started looking at methylation with regard to its effect on hormones and neurotransmitters way back in the days of Dr. Carl Pfeiffer. And we thought we were working at the level of neurotransmitters. Well, as time wore on and Dr. Walsh's research bore more evidence, we began to see that methylation was extremely important at a molecular level, at the level of DNA. So then we began to see that what we thought we were treating before as purely a neurotransmitter issue was now a DNA molecular issue. And when we were looking at what are some of the best tests, ratios, for example, the SAMe-SADH ratio, which is probably the best test for methylation, but it's not quite perfected yet, we began to see that we had certain qualitative pieces, and even the MTHFR were more qualitative, they weren't quantitative. But when we came full circle, and realized, wait a minute, we actually started with the test, the one test, that is truly quantitatively reflecting what the entire system of methylation is doing. We realized, what an interesting thing. We've come full circle back to a blood test with regard to the quantitative nature of methylation.